Hello, my topic for discussion today is radiation therapy at the time of corona, experience from a tertiary care health center in India. I have no conflicts of interest to disclose. Basically, my story outline deals with how the radiation treatment was continued for the patients during the crucial time of the COVID-19 pandemic at a tertiary care center in India. I will be dividing my talk into four parts. The first part is dealing with the physicians. The second will be with respect to the physicists, dosimetrists, and the technologists. And the third is with respect to the patient management. And the fourth is with respect to the infrastructure. Our hospital is a multi-speciality tertiary care center and it has 550 beds. Radiation Oncology department is equipped with the state-of-the-art TrueBeam STX linear accelerator. We also have a planning PET CT scanner attached to our department. Now coming to the physicians, how the physicians were managed and how did they look into the situation. The department consists of 3 consultants. The senior consultant is about 60 years of age and therefore we requested him to stay at home and in view of his high-risk condition. The remaining 2 consultants worked on alternate days. The first consultant worked on Mondays, Wednesdays, and Fridays, and the second consultant was working on Tuesdays, Thursdays, and Saturdays. On the third week, the second consultant would exchange the days. So instead of Mondays, Wednesdays, and Fridays, it would be Tuesdays, Thursdays, and Saturdays. If the first consultant falls sick, then the second consultant took over. As soon as the consultants entered the hospital, he or she would change over to scrubs, respirator, face shield, and head caps. It was something, in my terms, we can call it as a modified PPE kit. After this changeover, the consultant started his or her OPD. All throughout the stay in the hospital, social distancing was maintained. Before examining the patient, the consultant wore gloves and then examined the patient. For the ears, nose, and throat examination, care was taken to do the examination in a negative pressure room and no assistants were allowed other than the physician. After the physician completed his work, he would take a shower and changed over to his normal clothes and went back home. This is a classical way how the consultant was dressed up within the hospital with scrubs, a respirator, face shield, and a head cap. Now coming to the physicists, dosimetrists, and the technologists, we have a set of 2 physicists and 3 technologists. We don't have dosimetrists in our system. They were each divided into 2 teams. Each team consisted of 1 physicist and 2 technologists. The team worked on alternate weeks. There was an overlap of 1 technologist each week. The technologists wore the PPE as soon as they entered the department. One technologist, along with an oncologist nurse, used to do the patient setup while the other technologist was at the console. The same was followed for simulation and scanning. Before taking each patient for treatment, the couch was sterilized using alcohol-based sanitizer and was allowed to dry. Between 2 patients, a minimum gap of 15 minutes was allowed so that the proper sanitization could be carried out. Proper social distancing was maintained during all times. These are the 2 technologists who are in their PPE kit, along with the oncologist nurse who is also dressed up with the PPE kit, and they have maintained proper social distancing. Now coming to the most important part of this storytelling is how we manage the patients and how we streamline the facilities for them. All the patients from consultation were to be accompanied by only 1 attender. If patient is wheelchair bound or a pediatric age, then there were 2 attenders along with the patient. Each patient in the outpatient department have to maintain social distancing while being seated in the waiting area and within the consultation chamber. After it was decided that the patient required radiation therapy, the patient underwent COVID-19 testing with an RT-PCR. If COVID-19 was negative, then the patient is taken up for planning and simulation. If patient is positive for COVID-19, then patient is sent to the flu clinic for the needful. Till the patient is tested negative for COVID-19, he or she is not taken up for further radiotherapy management. All patients had to wear a mask and maintain social distancing. Time gap between treatment of two patients is a minimum of 15 minutes. Every week, rapid antigen test was done and followed up accordingly for each and every patient. Based on the diagnosis, hypofractionated radiation therapy was preferred depending on the choice of the patient. If patient needed admission, they were admitted under the care of the medical oncologist who had a separate department. If the patient developed any emergencies, then they would come to the 24/7 emergency department. They would undergo rapid gene testing for COVID-19 and then managed accordingly. Patients were requested to go to the flu clinic for any COVID-related symptoms. Infrastructure. The entire department was cordoned off from the main hospital with a single entry and exit gate. The patient waiting area had one vacant chair between each seating. The patients and attenders were screened for temperature and saturation before entering the premises. The oncology nurse took a detailed whereabouts of the patient and the attenders. Each seat of the patient was cleaned and sterilized before the next patient occupied that particular position. The deep cleaning of the machine was done at the end of patient treatment every day. Cleaning of the couch and simulation area was done before each patient's treatment and completion of treatment every day. No treatment was done on Saturdays. Only patient-related quality assurance was done on Saturdays. This is the classical layout of our hospital, in which the entry and the exit gate is a single one, and the patient had to come in and out through this particular gate. This is the seating arrangements. You can see that the red marked area is a non-seated area, and there is a gap between two seated areas. After the lockdown from 21st March 2020, we have treated 70 patients till 31st July 2020. It's still an ongoing process and treatment continues every day. None of the consultants and staff were affected by the COVID-19. 3 of our patients were positive before starting planning and were treated accordingly for the COVID-19. None of our patients were positive during the course of treatment and successfully completed radiation treatment. By following these strict techniques, we were able to successfully continue treatment of all our patients. Our model was later on followed by all the other oncology-related hospitals. Now, based on this technique, there's a small incident which happened in our department, and I would like to name this as a stitch in time saves 9. After we implemented all the necessary precautions during the COVID situation, this incident came into being, and it happened to one of my own patients a couple of days back. This is regarding a 54-year-old lady who was diagnosed to have a renal cell carcinoma post-radical nephrectomy in January 2019, and it was done in a different city and a different state, which was far away from my hospital. She was asymptomatic till 2020 July, when she developed headache, nausea, vomiting. She also developed minimal weakness in the left upper limb. In view of these problems, she immediately flew to our hospital by a 3-hour flight. Before coming to our hospital, she had got a COVID testing done at her hometown, which was negative. She was evaluated at our hospital, and brain MRI showed a space-occupying lesion in the right parietal region with surrounding edema. PET-CT was also done as a part of the metastatic workup, which showed multiple lung metastasis in both the lungs. This is the MRI image, which showed a well-defined circumscribed lesion in the parietal region, and which had a surrounding edema also. And this is the PET-CT scan, which showed multiple lung nodules, metastasis in both the lungs. In view of the solitary brain metastasis and the patient being symptomatic, patient underwent an excision of the brain metastasis. Histopathology was later reported as metastatic renal cell carcinoma. After the suture removal, the patient was referred to radiation oncology department for stereotactic radiosurgery to the tumor bed. As a part of a pre-radiation workup, we sent the patient for COVID-19 testing. Unfortunately, patient turned out to be positive for COVID. After the results came as positive, the patient was informed immediately. The government officials were also informed at the same time. So we informed the patient to visit the flu clinic. At the flu clinic, as she was asymptomatic for COVID, patient and relatives were advised home quarantine. After 14 days home quarantine, patient was tested for COVID-19 and was found to be negative. Later, she was simulated and taken up for SRS, and we also completed the SRS within that time. By acting in time, we were able to stop exposure to other patients and staff, and hence we averted a major disaster. Thank you, and the end.